invite you as our friends to some of the seminar work that we have, just for you to also get to know what more are we doing in terms of the commitment that we have, especially on this project. So the Eastern Cape is just the first province, and obviously we like to do that with the help of the province to really get the first date. And so this is the first province where we are actually launching and disseminating the results. So we are just excited on how proactive the province has been to get things together. And we are hoping that we are going to learn a lot in terms of what is it that we can do, so that if we have resources to do this again, we can even prove it and ensure that more people are able to join as well. So we are going to have questions later that would also just ask you about the reflection in terms of what is it that you think we can improve, what do you think we can add on as well. So if you, just to as you were walking in, you were presented with a gallery of photos. We collaborated with SANAC on that, and Dr. Sahir Parker led this activity where we looked at, when you think about HIV in terms of where we started and where we are today, there's a lot to reflect on. And there was so much information that was given to us that was over me. We thought, let us stop on photo 12. So we want you to take this opportunity as well to just reflect on the journey, especially as people that have dedicated their time in many various forms to work or invested work in HIV. Just reflect on what these photos mean to you, and how would you want to express it? So we still encourage those of you that have not scanned the barcode to scan the barcode, join in the Mentimeter, and ensure that we are able to capture some of those reflections that we need today, we need to hear from. And then the other thing that we did as you were registering is that we gave you a little bit of a gift bag. You also have a program in that gift bag that shows you what we need to do today. We still hope that by 3:30 we will end our day. So we have 3 sessions that we planned. The first session would be more about the introductions, the presentations from the province, just for us to get to know the province. And then the second session will be our findings, where we share with you the findings that we have in terms of the province. And then the third session will be more of a feedback. So we encourage that when we give you activities, you share and amongst each other, and then we are going to ask a representative to then reflect on those. So just going back to the first response that or question that we asked from the Mentimeter, it was around your expectation for the day. And I don't know if, Dr. Donna, you want to just pick on a few words, what seems to be coming up quite highly in terms of when we were asking you, what do you think? I mean, you have had an invitation for a while. You were told HSRC is coming to your province. We are asking one representative from your organization. There was a bit of information shared with you as well. Just what is it that you thought, okay, after spending a day with these people, this is what I would have gotten from them? So Dr. Dana will just read some of those activities.
Okay.
And, yeah.
Thank you, Doc. Good morning, colleagues. Thank you for the introduction, Doc. One of the things that I see coming up quite clearly here as something that colleagues would like to know more about is the incidence in the province. As you know, we're trying to close the tap of new infections. So if we're to know where we are as the province, so that we can tailor-make programs to close that tap of new HIV infections. The other thing that comes up here is teenage pregnancy. We know as the province we do have a high rate of teenage pregnancy, or should we say child pregnancy in this case, because it's little children who are getting pregnant. So it's one of the things that are coming up on the screen. The other thing that is coming up, and which I think we need to discuss, is collaboration. Fortunately, Udok mentioned that we are now kind of friends, and she has invited everybody in the house to come to the seminars that the HSRC holds. So collaboration is important because we can't win this. We know we were not supposed to use combative words, but just for today, let's just use them. We can't win the battle in this response to HIV and AIDS if we do not collaborate. We are working in silos. So collaboration is coming up as well. Yes, of course, to learn more about the HSRC. I think people are interested to know who you are exactly. I know you came, as you said, that whenever we call on you, you do come to our assistance. We wanted you to share some information on the TB survey that you did, and today you are coming to share about the National Household Survey. So for now, those are the things that I think we need to think about: the teenage pregnancy, the incidence, of course, the collaboration is something that we will have to talk about going forward, and exchange of knowledge, that is that collaboration element. Thank you, Doc.
No, thanks. And just to, as I mentioned, some of these conversations are going to continue beyond this room. So there are things that we may not be able to provide more detailed information on today, but we promise you that we would then ensure that it's something, if we have enough data, create time to then come back and just report that the province will just help us create an opportunity for us to engage. Wanting to know us or know more about us is what excites us. So we have in each table a colleague from the HSRC that has worked so hard towards preparing the data that we are going to share, or the findings that we are going to share today. They've also worked so hard towards the preparation of the report that will be shared with you later on. So we are going to later give you an opportunity to introduce each other. You have the whole day for them to tell you about a lot of beautiful work that we do. Ne? So we have covered you with that one. You will get to know each other. We will share our contact details, and we will make sure that the friendship, because we like having friends, the friendship really gets strengthened within a day. So I don't know if we can move on to the second slide, just to talk about the exhibition as well. So this is the slide where we were asking you to reflect on the pictures that you have seen. And obviously we know there are so many we could have included, as I've mentioned, but what we have selected, what thoughts, emotions was brought by that. So our IT will just reflect that on our screen. And then while we do that, you will note that we pre-selected or allocated seats for you, so you didn't choose to sit with someone that you knew, but you are sitting with someone that is important to know today, in addition to knowing us. And the reason for that is that we wanted to diversify the discussions that we are going to have, right? To make sure that in as much as you are going to talk about your work, you also learn about the work that the other is doing, so that the idea of collaboration is not just about collaborating with us who are far, but also collaborate within the province as well. So, Doctor, that is the nice thing about having people join online. You also get to go into their home and then come back to the venue. So, Dr. Dana, do you want to also just, okay.
Okay. As Doc said, with those photos on the side of the room, how did they make you feel? So somebody says it made them feel emotional. So there's something that was touched inside them by looking at those photos over there. And somebody says that, as I said, we are not supposed to use the combative terminology, but here it says it has been a long fight against HIV. So it's one of us colleagues here who feels that we've come a long way. Somebody else said that it's informative. So there is something that somebody has picked up that has made them to be aware of, maybe something that they were not aware of. So some information has been shared with them just by looking at those photos over there. And there's been improvement in HIV management. So that's something that one of our colleagues picked up by looking at those photos on the side of the room. And I'm not going to read the whole board, but they say it's impressive, so you've done something good, Doc, by having those. So as it's always said, a picture talks or says a lot more than a person can say. Yeah, thank you.
Yes, and that's what we wanted to make sure that we say a lot. And I'm sure as we discuss over lunch, we will not use one word or two words to express it. We will just be more detailed as well. So as we start our program, we're just going to allow about 10 minutes for you to know your neighbor, to look at your neighbor and get to understand or know them. When you look at your neighbor and get to greet and know the neighbor, also look at what makes them unique, which is the third question that we also ask. We would like them to share with you what they think makes them unique, which organization they come from, right? After that, we're going to ask a representative. So we want today to also have leaders coming out of this discussion. You are going to vote for a leader that will represent your little country that is your table there, so that that leader can also speak and represent what you thought. So they'll just talk to what organizations are represented in that table, what they think, what is the common thing that colleagues mentioned about which makes them unique, right? And then after that, we would also be allowing to move into calling Dr. John Bedford, who will also give us words of encouragement as we start, and who has also been with us for a very long time, provided support and held our hand as we've been launching since last year some of these fundings, especially at national, we've launched internationally, and now we are localizing it to the people as well. So just that, I'm going to allow you to talk amongst ourselves, so we will zip a bit so that you get to know each other as well. Thanks.
So 10 minutes.
Yeah, 10 minutes. Okay, colleagues, and that's what we want. We don't want people sitting and being alone in front of, when they are sitting alongside other people. So the conversation that you have started is just the beginning of many, we can just pause a bit, the laughter we want, the smiles, the connection we want, but we can just pause it and we have 1 hour during lunchtime and on our way home. If possible, those that are walking home, then at least you have a conversation that you'll have while walking home, especially those that are coming from close by communities. So colleagues, we've just noted that some of our colleagues have just joined us, and we really want them to participate in this activity. So we're going to push it down to later on after lunch when you give feedback that representative that will be talking on behalf of the team will then just briefly introduce who is in their table before they talk. So I'm going to move to the item number 4 on your program, where I would want to call Dr. John Blandford, who is CDC South Africa Country Director, just to address us in terms of what it means for them, for us to be able to disseminate these findings at this level, which is a great milestone for us. So if you can just clap hands for him, or if you want to do your shine, you can just give him the shine. That is still allowed as well. Thanks.
You're too kind, thank you. Good morning, all. It is a very good morning. So I want to welcome all the colleagues here from the Department of Health, from the Department of Social Development, Department of Education, from SANAC, from the Eastern Cape AIDS Council, the many and diverse representatives of civil society that are here today. Ladies and gentlemen, all protocol observed. First off, I want to congratulate HSRC, its partners, and the government of South Africa for completing the 6th National HIV Household Survey, and for its impressive legacy for leading these national HIV surveys in South Africa over the past 20 years. This is the largest survey of its kind that's done globally. And it's one of the few that's actually done by the local institutions. SABSSM is a survey led by South African scientists to improve the lives of South Africans. As such, SABSSM demonstrates how investment in key partners and institutions established a legacy of country-led data, country-owned data, infrastructure and capacity to respond to current and future health threats. As the U.S. Centers for Disease Control and Prevention in South Africa, CDC, we're proud to have collaborated with HSRC on this important survey, and we've been partnering with HSRC since 2005 to conduct the SABSSM survey through both financial and technical support. This collaboration, now approaching 2 decades, has been made possible by funding through the U.S. President's Emergency Plan for AIDS Relief, or PEPFAR. And CDC, along with USAID and Peace Corps, are all implementing agencies under PEPFAR in South Africa. As we gather here today, our dialogue is just the beginning of a conversation with the Department of Health and partners and civil society about using the SABSSM data to inform program strategies and planning in Eastern Cape into the future. As with previous rounds of this survey, the SABSSM team has already made granular data available to guide programming for HIV care and treatment and prevention interventions, including data for HIV estimates at the national, provincial, and district level. So we see these utilized in the Tembisa and Naomi models that will guide our programming. As already discussed, the national findings have been released here in South Africa and most recently in Munich at the International AIDS Conference. And these findings are encouraging in demonstrating how South Africa's HIV policies and programs have contributed to stabilizing the HIV epidemic, have increased the levels of population viral load suppression, and we see promising trends in HIV prevalence and incidence among adolescent girls and young women. The surveys helped us understand where we've made great progress and which areas and which populations we still need to focus on in the future. With these data, we can strengthen our programs on HIV prevention, including testing, especially for men and youth. As we see and discuss the results of SABSSM VI and their implications for the HIV response in Eastern Cape, we need to remember the very different context we are in from when the first study was done in 2002, more than 2 decades ago. And the photo exhibition is quite helpful for us to recall that long history. From a time when treatment was not easily accessed and when there was more despair than hope, we now have a highly effective treatment that's widely and freely available. The treatment not only preserves lives, health, families, and communities, we now know that ART prevents onward transmission of the virus. This is the foundation of U equals U, or undetectable equals untransmittable. A person on ART with an undetectable viral load has 0 risk of transmitting HIV to their partner, 0 risk. I'm proud to be standing here in Eastern Cape this morning. This is the province that launched U equals U in 2022. Earlier this year, the Minister of Health launched U equals U nationally. So thank you, Eastern Cape, for leading the way and being at the forefront. And I think it's appropriate that we are also at the forefront now of looking at the provincial and district level findings here in Eastern Cape, which we will replicate in the other provinces over the next 5-6 weeks. So we need to focus on who does not know their status, who's not on treatment, who's not virally suppressed. These are the sources, the drivers of the new infections. We need to understand which populations we need to get onto treatment. Those who are on treatment and virally suppressed should be loudly celebrated, not stigmatized. The SABSSM data will allow us to target our efforts towards finding and linking people in need of treatment and key prevention services. By focusing the lens on provincial and district level data, today's dialogue sets the stage for continued discussions within Eastern Cape about how the data can inform the HIV program and strategies to best meet the needs of the communities. Finally, I would be remiss if I did not acknowledge and thank the more than 10,000 residents of Eastern Cape who contributed to SABSSM VI by opening their doors to the HSRC teams and participating in this important study. So thank you, and I look forward to the discussions today.
All right. Thank you, Doc. Thank you for that. Now we're going to call upon our colleagues from the province, the Department of Health, to give us the status quo of the HIV, TB, and STIs in the province. And we would like to call on Mr. Somaila to come to the podium. After Mr. Somaila, we will get a presentation from our chairperson of the civil society in the province, Mr. Melikaya Lusiti. So Mr. Lusiti, just after Mr. Somaila is finished, I would like you to please come forth and give us your presentation. Thank you.
I'm not sure who's going to be projecting. Is it me or is it projected somewhere? In the meantime, good morning, colleagues. Can I do that again? Good morning, colleagues. Good morning. Oh, okay, that sounds better. I'm not sure whether you are angry with me or what. And I'm not a really good-looking guy to look at in the morning. Colleagues, I'm asked to present the status quo of the HIV program in the Eastern Cape, but let me firstly indicate that this is more of a section of what we will normally want to reflect in terms of the National Strategic Plan priority indicators or goals that we wanted to measure. It will only talking to a greater extent to issues that are related to strategic goal 1 and 2. So basically, which is more on what is within the scope and the responsibility of the Department of Health. So I will be reflecting how we are doing, particularly around the biomedical interventions, and reflect how we are moving with regard to that. The next slide, please. Am I supposed to be moving it, using this one? To change it. Oh, okay. So I don't have to ask anyone to change it for me. Colleagues, this is just to share with you the framework of how we are approaching the coordination and how we are aligning interventions and activities that are aligned to the implementation of the program. So this is a strategic slide for us because it places everything at the right spot in terms of the treatment cascade for people living with HIV and TB. We're categorizing this into 5 pillars, pillar 1, 2, 3, up to 5, starting from prevention, which is pillar 1, to case finding, and also those that we have managed to find, putting them on treatment, and again, treating them successfully. Then if they are treated successfully, we decant them through the implementation of the DMOC strategy. So this is a kind of like a framework, and all the activities and programs that are falling within a specific pillar, you will see that we have categorized them. If you look, for example, pillar 1, we'll talk about prevention interventions. And we will be reflecting in terms of how all of these are performing in terms of the data. And I also just wanted to stress the fact that, colleagues, that this is more funded from the conditional grant, from the National Department of Health conditional grant, including the supporting components, which is called ACSM, Advocacy, Communication, and Social Mobilization, and also the capacity building component, which is your regional training center activities. And you see they are cutting across all the 5 pillars, and also the monitoring and evaluation. All of those are funded from the grant. But also we are appreciating that as the Department of Health, we cannot win this fight alone. We have to collaborate and partner with everyone in the HIV and TB response platform. Hence, we're seeing that the AIDS councils are the enabling platform for us to collaborate with different sectors, different formations, different departments, and all of that, which we believe are making an input into what we need to be achieving as a province. So that is very critical for us. And also, another area is the issue of the role played by the developmental partners in the province. There's a lot of investment in the province from different sectors, different NGOs, funded, PEPFAR here, CDC, USAID, Global Fund, and all I could mention. All are contributing into what we are doing as a province. We need, therefore, to acknowledge them and appreciate them and place them in the right spot. But I still have an issue with them. They don't want to divulge their past to a point that I don't know what they are bringing us. But that is by the way. And also another critical sector we feel is very important to work and collaborate with is the schools of higher learning, particularly for young people, the student community. So what we have done as a province is to establish a working relationship with the 5 universities and TVET colleges in the province by signing formal MOUs to collaborate on the prevention intervention initiative. So that is a package of what I'm going to reflect going forward. It is the output of this collaboration, and that we need to note. Am I still pressing the right one? Why is it not moving? Oh, thank you. What you see, colleague, here, I just wanted to share with you where we are with our 95. This is an overarching goal as a province that we want to see and achieve. And this is where we are, as a province in relation to, maybe as of end of March 2024. We are sitting at 94.80 and 92 for the 95-95 cascade. I think we needed to give ourselves a good round of applause, because on the second 90, we have managed to achieve the 80% mark, which we have been struggling. I will explain more around why we have been having a challenge around that part. But again, you could also see with other segments of the population, just to say, where are we in terms of children? We are not doing well, if I may say. We are sitting at, for children, we are sitting at 84.73 and 69. And for males, we are sitting at 92.74, 93. And again, which is performing better, are female. Oh, it should be this one. Oh, thank you very much. This one is a kind of like showing, comparing the province with other provinces in terms of where we are with the 395s. For the first 95, we are, as a province, as I'm saying, we have a total of 837,000 patients that we have confirmed as a province that they are HIV positive. And in that part, as a province, we still have to cover about 13,000 overall to meet the target. And you could see how we're faring when we compare it to other provinces. But in terms of the second 95, we are sitting at 659,000 patients that we have currently on treatment. And we still have, as I indicated earlier, about 139,000 to take us to the target by 2028. As of, with regard to the third 95, as a province, we are sitting at 92%, as you could see there. And when we are compared to other provinces, we are not really doing bad. We counted, we are actually above the 90% mark. This is just also to indicate our ARD coverage. Patients that we have managed to put on treatment, and as you could see on the slide, the light green and the light blue indicates the gaps that we still have to catch up, to close in terms of the patient that we need to put on treatment. It's not moving. It's our jumper. What am I supposed to do? Or what am I not doing right? Oh, they are. Colleagues, this is just, I'm going to just quickly give you an overall performance for the whole year, 2023-24. This is what I thought I needed to reflect to you, the whole year picture. I have not included Q1, but I just wanted to share with you what we shared during the end of financial year 2020. Okay. Prevention strategies. We have got 3 areas that we are monitoring around prevention, 3 or 4, if I may say. This one is about our ANC antenatal care that we are putting on treatment to prevent vertical transmission. As you could see in the picture there, as a province, we are doing very well in enrolling patients on ARVs that have tested positive during their ANC services. So basically, and I think we needed to applaud our district and the support by the partners that we have come a long way in this indicator, which has been a problem is around the reporting component that we have been finding a challenge. As of end of financial year, we were sitting at 99% at initiation on pregnant women. And every time you see a green, you must clap. Now, this is the outcome of that intervention, colleagues, in terms of the positivity on children at birth. We are sitting at 0.6%. The target must be less than 0.5%. We're sitting at 0.6% overall. Then at 10 weeks, by end of the financial year, we're sitting at 0.4% against a target of less than 1%. And in terms of at 6 months evaluation, testing, we are sitting at 0.7% against a target of less than 1%. In terms of the testing at 18 months, we also doing well there, although we do have those pockets in the certain districts around Q4 where we had more than the target of more than the 1.2% in Chris Hani, Joe and in Nelson Mandela. I mean, Sarah Batman, but overall, as a province, we managed to achieve 0.4% in terms of positivity for the 18 months. Now, let's go to condoms, one of the prevention strategies. The province had, as we all know, 2023-24 was preceded by, was following a year where we had a lot of challenges around the condom availability and distribution. By 2024, we have seen quite an improvement with regard to condom availability, to a point that we managed to achieve by end of the financial year an average of 80% to the targets that we were given as a province. You could see that there are still districts that were experiencing some challenges, like in Amatole during Q3, but overall, we're not doing bad. But I do want us to note something I want to make reference to, which is Chris Hani, which has consistently doing well with regard to distribution of condoms and overachieving that. But I'm raising this because I want to make a point around this part in the following up slide. This is female condoms, colleagues. I'm not sure whether ladies do not want this condom to be procured and supplied and provided and distributed, because we are not using it. And therefore, the demand for this condom, we are struggling to pull up this performance with regard, and unfortunately, it's the most expensive one compared to. And people, as much as maybe it's one of the areas that needs to be researched, colleagues, in terms of why are women not using female condoms. And therefore, the intended purpose of introducing this intervention is really not, we are not achieving it, if I may say, because of the low performance. Generally, we are not doing well with the female condom distribution. STIs, we are using one indicator to monitor STI as a proxy indicator, which is your MUS. As you can see, colleagues, this indicator has a dual purpose, if I may say. One is to monitor whether we are having high incidences of STIs in the province. And also, we have also an interest to find the STI cases and manage them efficiently so that we could drop. But the province has been burdened by a consistent increase in the number of STIs. Initially, we thought that it was because we had a challenge around condom availability a year before last year. But even when we have condoms available across the province, we still see high incidences of STI. Chris, and the point I wanted to make, you heard that I said they are doing very well in condom distribution, but they are the second highest in the incidences of STIs in the province. I'm not sure whether then can we learn anything or can we consider anything around that in terms of correlation of the condom. We distribute them. Now the question is are they using them? But I wanted to believe that one of the reports that is going to come on the HRS, on the presentation to be made, it's got something that will be talking, I hope, to this issue of the use of condoms, because we are seeing high incidences of STI, and we think we need to be concerned around this part. Sexual assault and the giving of the prophylaxis interventions to prevent transmission. We are not doing well, colleagues. As you can see that we are not coming even closer to achieving the target on this one. We are giving this PrEP, the PEP, post-exposure prophylaxis, as a standing on the sexual assault cases. But there is an indication that as much as we are picking, people are coming to our facilities, but we are not giving them the prophylaxis. We have a concern on this indicator, colleagues, because there is the denominator, if I may just say. The denominator is including those that are already on PrEP, on treatment, HIV positive, and we have lifted this issue to national to say they must exclude the ones that do not qualify to be considered for PEP, because it's changing the picture. And what we see here is a wrong denominator, but we cannot now know whether we are doing well or not, because it's a very clouded indicator. So the new needs, as we are developing it now, that will have to be considered in that aspect. Then in terms of PrEP distribution and availability, the province is trying and has worked actually towards achieving the target of issuing out PrEP across the province. And I think, as you can see there, at the end of the year, we had an average of 90% achievement towards the target we were given by national. I'm kind of rushing, colleagues, because I noticed that I was given 15 minutes, so I don't want to take much of the time. Then the next slide will talk to, which one is that one? Or the initiation of TPT, which is TB prevention therapy on all HIV positive patients. As you could see here, colleagues, we are sitting at 90% average. There are districts that have not done well, that have not achieved the 90% mark that we were hoping that they will be achieving. So averagely, you could see over for the whole year, we have achieved 90%. I'm not going to talk much on the notes, colleagues, because it's going to take a lot of time. Case finding, which is your first 90, your first 90, the testing, HIV testing services that we are doing as a province, in terms of volumes of tests that we are doing, we are achieving the target, and that is consistent throughout the year on all the quotas. The target for the year was 1.6 million tests that we are supposed to be doing as a province. And we managed to do 2.1 million so as a province. So we are doing the test. I think we need to note that. But of concern, colleagues, is this picture of finding them, the positivity yield. Consistently, this picture shows that we are not able to find the positive patient that we believe we have in the province. I'm not sure whether what is it suggesting, because consistently over the past 3 years, our yield has been going down to a point now it is sitting at 2.4%. And ideally for us to be able to achieve the second 95, we need to find the positive cases and put them on treatment. So it's a concern, and we've been asking ourselves as a province, should we be resolved on the position that says we are winning the prevention of HIV infection in the province, or should we be content with that? But we'll hear more maybe on the study in terms of what is the current incident in Eastern Cape to tell, so that we could be able to align this picture that we are seeing. As much as we're doing high volumes of tests, but we don't find, maybe our interventions are not targeted in terms of who to be prioritizing for testing. This test as paying, but this is an area that as a province on all sectors we have been looking at. Treatment initiation, which is relating again to your second 95, because of the low yield, we are given a target of putting patient on treatment. But because of the low yield or in our ability to find those patients, we are not able to find the eligible patient for initiation on ART. to a point that if we're looking at the eligible and versus the target, we find that we are finding only 78% of what we are supposed to be initiating. As a result, we are not able to achieve our target for new patients put on treatment. Now, but if you look at our initiation practice, are we initiating those that we managed to find? This slide demonstrates that at least we are achieving 91% of those that we managed to find on a month-to-month basis or quarter-to-quarter basis, suggesting that the issue is not about the practice of not initiating, but the challenge might be around the issue of finding them and putting them. So this indicator, therefore, affects the second 95 in terms of us being able to scale up our initiation. As you could see in this slide, I need to correlate what I'm seeing here and what I'm pushing. Colleagues, this is what I was talking about, the eligibility issue. Because we can't find them, so our patient eligible to be started on treatment, it's sitting at 78%. So this is where we are. Now, but if we look at this one, this slide, it shows that our practice in terms of initiation, we are initiating patients, those we manage to find. As much as we do have those districts like Nelson Mandela, where you will find that they are only initiating averagely 78% throughout the year. But generally, all the districts are achieving more than 90% or more than around 95% initiation rate. But now, if we look therefore, how are we performing towards our target that we are given on an annual basis? We have only managed to achieve 71% of that. Basically, what it suggests that what we are expected to put on the second 95, we can't achieve that target because we can't find the patients that we are supposed to be achieving because our yield is low. So it's something that we need to appreciate, colleagues. Generally, our total remaining on treatment, that talks to our retention and is part of the second 95. We are able to achieve the target, 90% of the target that we are given. As you could see that by end of the financial year, we're sitting at 92% of what we are expected to achieve, suggesting therefore that we are progressively, we are, as much as we at the beginning of the year, we are increasing, we're achieving the number, but towards the end of the financial year, we are not achieving consistently what we have managed to achieve earlier in the year. This is one of the things we are finding it a challenge. We have got a high loss to follow up of patient on treatment. Hence, we are not able, we introduce patient on treatment, but some we're finding it a challenge, but it's not taking us far away from what we are expected to achieve at the end of the financial year. The fourth area, the fifth area that talks to the DMOC strategy, which we are expecting to be enrolling all patients that are on treatment, decanting patient. We are given a target to decant patient for the year, but for up to the end of the financial year, we have managed to achieve about 55% of that targeted patient to be decanted. The modalities, colleagues, of decanting is a facility-based pickup point, external pickup point, and also the adherence clubs. This is where you will see where you will find most of the patient. In terms of what you see here, why am I not using this one? The Tatangenyengo, okay. Here is a picture that I'm talking to colleagues. This is the target that we are supposed to be achieving, right, 55%. But in terms of taking the patient out, collecting the medication in the facility, collecting them in the community, or collecting them in terms of the adherence clubs, there is a portion allocation of that we're expected to achieve of 20, 30, and 70. 70 more at a community level, 20 in a facility, and 10 in the adherence clubs. But what you see here, colleagues, we are sitting at 54% and in the facility. More patients are still collecting their medication from the facility. And only 38% that is collecting it from the pickup points. And therefore, and also the data collecting the adherence clubs is only 8%. I'll run through TB just to give a picture of where we are with regard to TB. In terms of TB start rate, our target is for DSTB particularly is we are sitting at 90. Our target is 94%, which we're supposed to be initiating on TB, on treatment that have been tested and confirmed. But by the end of the financial year, we are sitting at 91% of the target, which is below the 94% of TB treatment initiation. And the treatment outcome for TB, we've got those two attrition points, practices, which is your success and also your loss to follow up. The treatment success is sitting at 72%, and in terms of loss to follow up for TB, as you can see, we are above the 12% mark or percent. We are sitting at 13.9%. And you will see where mostly all these patients are coming from. The highest will be your Chris Hani and your Nelson Mandela, and also the Sarah Batman. Those are the districts actually will find most of the patients that are getting lost on treatment. The HIV positive on ART, that means the ART initiation on TB patients that have been confirmed to be positive also for HIV. Our ART initiation for that, the infected patient, is 94% by the end of the financial year. And across the province, you'll see that there is an achievement to a certain degree, but there are districts that are still experiencing some challenges of achieving that. In terms of the RTB, this is a long regimen treatment outcome, colleagues. You can see, long regimen here, you will see that the treatment success for that will be sitting at 50%. The loss to follow up is high at 21% against a target of 12%. And in terms of the STB death, the RTB death rate, we are sitting at 22% against a target of 6%. This is a long regimen. It's not moving, ne? I'm not moving. Yeah. I am on this slide in terms of long regimen outcome, colleagues. I'm almost done. No, I'm almost done. Yeah. Basically, colleagues, there are various interventions that are being implemented in the province to try to, in line with that, framework. There are a lot of activities that we are doing. I didn't go into details with regard to that are looking into that. But what I can summarize say, for TB program, we are implementing what is called TB recovery plan, which is a national strategy. I want to believe that most of you have been introduced into that TB recovery program plan. So we are implementing that as well in the province. And in terms of HIV, we are strengthening and implementing the Operation Putuma. And in the province, we were earmarked, or we were given 4 facilities to focus on, while we are also considering all the other facilities as well. We are targeting that. As you could see in this slide, that the intervention in these 4 facilities actually are seeing an improvement in terms of what is expected to be achieved. My apology to colleagues for not coordinating these slides together. Thank you very much, Chair.
Thank you, Mr. Somaila. Thank you so much, even though some of the slides we could not see, but we heard what you were saying. Thank you so much, sir. Now I'd like to call upon Mr. Lucity, who is our chairperson, the provincial chairperson of the civil society. And by that, he also is our co-chair as the Eastern Cape AIDS Council. So, Mr. Lucity would like you to come on board and give us your presentation as both the chairperson of the civil society provincially, as well as our co-chair as the Eastern Cape AIDS Council. Thank you.
Good morning to everyone. I've got a disclaimer here. Before I start, I don't know how to use this thing, firstly. I know that now I was supposed to press green and red, now I see two greens. The presentation was supposed to be on behalf of the CSF, but I guess the co-program director, Unkwile Zanzu, and she says I must perform my duties as the co-chairperson of the Eastern Cape AIDS Council. And I guess the first thing, as much as I see there was welcoming done, this is the province of the Eastern Cape. It's only appropriate that someone leading the province welcomes you. Welcome to everyone that's present. Thank you. Currently, as a civil society forum of the, sorry. I forgot to greet. That's one thing I was taught at school, always greet. I just welcomed without greeting. To the program directors, the partners who are present, particularly CDC, HSRC, fellow colleagues that we've been working with. I can see FPD is here. No, sorry, Desmond Tutu, I can see Beyond Zero, our principal recipient is here. I can see the department, okay, I won't say the Department of Health, who Tatu Somaila just presented on behalf of the department. I can see social development. And the rest of the partners that I haven't mentioned, I greet you all. As I said, as a civil society forum, we currently have 13 of 18 sectors. As you know, that we are the provincial chapter of the South African National AIDS Council. And the National AIDS Council has got 18 sectors, of which during our elections this year we were able to elect 13, which you can see there. And then sectors that still need to conduct their elections are the children, the women, men, sports, arts and culture, and the youth, which are very critical sectors that we need in the response. And as we speak of adolescent young people, and also I think what Doc spoke of AGYW, and we can see that women and men and children are not yet formalized in this response. But fortunately, currently, the children's sector nationally did give us an interim structure to work with, so that we were able to work with them in conducting the elections. As you would know, the Eastern Cape has 8 districts, which is your 6 district municipalities and 2 metros. We've got leadership in 7 of the 8. The only one that's still outstanding is Sarah Parkman. That's the provincial leadership, which is also the coordinating committee in the province for the Civil Society Forum. It's chaired by myself, Melika Lucity. The first deputy I saw, she's here. ngicela uphakame sihlale. That's uZonke Sibiya. The second deputy I saw, he's here, Umzoxolo Boyana. Ngicela uphakame, Mr. Boyana. The secretary is here, Mr. Numa. Our deputy secretary sent an apology, Mr. Bekwapi. Our resource mobilization convener is here, Ms. Skepe, my fam. The deputy RMC sent an apology. The program review convener, I saw her, I came with her. Maybe she's just gone out quickly. And her deputy, Ubaugaba, Mr. Sandlana is there at the back. Thank you. I guess it's 15 minutes. The districts, I will just read out the chairs and not necessarily the whole top 5. I saw the Alfredo chair is here. Ukomre Tundabal. Phakama Mhlekazi. Amatole, Mr. Chele, I was trying to look around the room. I haven't seen him. Maybe he's held up somewhere. Our host district, Okanye Metro, our host Metro, the chairperson of the PCM AIDS Council, Umfundisi Novuka is here. I saw Ungibane, the district chairperson for Krisani, he's here, Mr. Soleka. Mr. Matwa, I haven't seen him, but I believe he's in, my apologies, chairperson. That's Joe Gabi, Nelson Mandela, Comrade Uno Kambola. I saw him, he is here. I believe the OR Tambo chairperson is online. Mrs. Ndinisa, thank you. I guess our role, what do we as CSF commit ourselves? I don't want to use the word commit really, because you can't make commitment without funds. What do we foresee as our role if we did have funds? We want to be in the space of behavioral change and promoting condom use, share and lead strategies that will avoid condom dumping. And I think, as we've heard, that condoms are being distributed, but there's an increase in STIs. And then try also, as part of behavioral change, promote abstinence and faithfulness in the areas of pastoral care. So that's our faith-based sector. They feel strongly about that. Awareness and sensitization of care workers, healthcare workers, and communities regarding acceptance of our key populations, addressing stigma issues, and disclosure. Demand creation for DMOC modalities through advocacy and social mobilization, as we've heard that a lot of people are still accessing their treatment at facilities. So we want to promote that and create or strengthen adherence clubs and our support groups under the IACT program. Also drive awareness and popularize, drive awareness and popularize TB self-screening innovation, encourage people with TB symptoms and population at high risk to get tested for TB, particularly your people living with HIV, your pregnant women, your TB household contacts, ex-TB patients, and ex-minors. We drive the awareness and popularize BPAL, which is a short course treatment for drug-resistant TB. demand creation for people living with HIV to access TPT and prevent active TB. Involve ourselves in programs that will access men where they are, which as I said, is quite imperative for us to have these critical sectors. As I've said, men, women, youth, and children, we still have those sectors to mobilize, and we really need men to access them, and we really need men to take up health services. Create awareness and noise on issues affecting children. We need to speak to the parents, we need to speak to the guardians, we need to speak to communities. Because in instances you find that guardians and parents who are also on treatment, they are very suppressed, but they have children who are not. So therefore we need to discuss these issues. We need to put up the numbers when it comes to 95 for children. Hence we say we need to really make noise on issues that affect children. Health talks with guardians in different platforms, which we will create jointly with the children's sector. When you speak of guardians now, it's related to the children as well. Nearly done. Strengthen, is my time up? Oh. Strengthen on strides that we've gained on the U equals to U partnerships. Doc, we were quite proud as a province to be the first province to launch U equals to U. So now we need to really escalate it and make sure it's strengthened, and we actually need to bring it back because somehow it got lost. Maybe as a province we need then to resuscitate that. We need ways of working with HIV ambassadors, because we do know that we've got HIV ambassadors currently being assisted by TB HIV care at Krisani, Amatole, and Owartambo. So maybe this program, we really need lessons learned from it so that we expand it to the whole of the province. And not just HIV ambassadors, also TB ambassadors. We need them on board. And we need actually, as we know that there's a TB caucus and the TB task teams, we need membership there to be really active in ensuring that we respond in a manner that's expected of us. And provide psychosocial, spiritual support and pastoral care, particularly to people living with HIV and TB, and those actually who have comorbidities, because really what we found as people living with HIV, there's quite a mental health issue that's not being addressed properly. Maybe this now we need to look at it and find ways of ensuring that there's that support for people living with HIV and TB. Revival of candlelight memorials, World AIDS Day, and ecumenical dialogues. Ansakhumbula candlelight yenziwa nini. If you know the history of World AIDS Day to actually prepare for the candlelight, injalo bawujikijwa ndeti. When you do a World AIDS Day, is to prepare for the candlelight. But the candlelight somewhere it's being lost. We still need to remember and celebrate. And as we celebrate, we still have to talk and say, now we've got a challenge of saying by 2028, we need 95, 95, 95. And Uba Ugaba, O2 Vision 2030, Mr. Daile, it's dependent on this NSP/PIP. If we really want to really end the HIV, this is the NSP and this is the PIP that needs to respond to that. And civil society has a critical role in playing to ensure that these figures are being met. The challenges that we have as a CSF currently, as I've said, we can't commit because there aren't any funds or resources for us to do the programs. We attend meetings against the CSF a lot and talk a lot and make recommendations. And again, next year, you're going to speak about the same thing that you spoke of last year. So if somewhere, somehow, we could get that recognition, and I think maybe as this new coordinating committee, we should have an M&E team that will say, at this meeting, this is what we said, so that 3 months down the line, we are able to say, this is what we've said, and this is what you've committed as ECAC, this is what you've committed as social development, as education, as health, but nothing has yet been done. We've also having challenges of, we know that the CSF, before you become a member of the CSF, you must belong to an organization. And we've got lots of organizations that are assisting with loss to follow up, track and trace. But what we found is that a lot of facilities are not issuing out these lists. And I'll be controversial in this one, in as much there was a district CDC meeting that was called in Pretoria. And I said in that meeting, somehow we have learned that even facilities themselves, they are seen as failing if they've got less people who are in their facilities on loss to follow up. So maybe somewhere, somehow we're losing each other there, where we say that facilities keep the numbers on purpose so that they have a high number. We do need those numbers of unconfirmed people so that we get them back to treatment, so that we ensure that the Eastern Cape celebrates the 95-95 when we come to 2028. Well, as a CSF, we always expect stuff. The first one maybe is sharing of contact details of district health promoters for ease of coordination and linkages. What we've learned, a lot of people, when you do the loss to follow up, you've got 5 different people coming to Melikhaya at once. So maybe if we can share contacts so that we are able to coordinate properly, so that if Melikhaya is seen by Usia, we don't have already Novuka 10 minutes later coming to see Melikhaya for the same thing. Establishment of a advocacy and social mobilization committee with the CSF. I guess we do have community advisory boards, but we need to actually, as the CSF now, participate more so that when research is done, we are part of that research and we know what's happening in that research. And we need to be that link between CSF and the research institutions and the communities that they work in. And we'll need to be part of the provincial and district health forums, clinic committees. And, you know, we need workshops on the pickup points requirements for if Melikhaya wants this pickup point, what does his institution need? And then I guess train the CSF on risk screening tools, HIV self-screening, and TB screening tools. As much as some of us are leaders, you'd expect us, we know everything. No, we don't. We still need to learn. We still need to be trained so that when you speak something, you speak it in confidence and not issue out information that's irrelevant or that's non-existent. Also, training on the latest care and treatment guidelines. Also, capacity building opportunities to enhance the knowledge and skills related to STI prevention and care, and training on advocacy and social mobilization. Quarterly stakeholder engagements between the CSF and partners at provincial and district level. Monitoring of the implementation of the multi-month dispensing of art so that we are able to know that which facilities are struggling when it comes to drug stock outs. Upscaling of community-led monitoring. I really want to champion this one. We know of Richitze, great work that they're doing. And we know currently in the province there's also community-led monitoring done through SANEC. I think one of the districts is Buffalo City and the other one is Crisani. So we need to upscale that. And we need to partner with HSRC on community-led monitoring. If you remember, I think I said to Adla, maybe it was 10 years ago when I last met him, the Eastern Cape keeps pioneering, remember. We did community-led monitoring for people living with HIV in the province first. And that, because of the expertise that came out from HSRC and the results, the program got upscaled to national, and then also the TB component of it was added. So we need to revive those things. Because I think the last one, it's been a very long time. Maybe we can speak of looking, maybe of having now new data that will be available. And the good thing is that when it's community-led, it's peer-to-peer. And at least it's people who know how to speak to each other. Oh yeah, I'm done. Thank you very much.
Thank you, Mel. Thank you so much for that insightful presentation. I like the last part about collaboration, especially with the HSRC. They are here, so they've heard for themselves that we would like to revive some of the work that we started as the province, which, yes, maybe people at national level have more capacity than we do, but we wouldn't mind that you still come back and collaborate with us as the province. As well as the part on the loss to follow up, that you know the people you live with as the civil society on the ground. Maybe we need to collaborate with the DOH in finding those people who are lost to follow up, but that I will leave to the Department of Health to look into. I would like to, because we are pressed for time, but we will allow some questions, just 4 questions, and it's not because we want to close people out of the discussion, but because we know that we are cognizant of the fact that some people still have to travel back home later today, and we would like that we do not do hit and run on the program. So we will allow just 4 questions for now, and we're hoping that colleagues won't take it as we are closing them out, but I would like to suggest that we continue with the questions during tea break if we still have some questions that we would like to ask from our presenters. For now, just 4 questions that we will open time for. Any takers? Questions and points of clarity, please. Unless we're saying that the questions were, the presentations were quite clear. Ms. Bottoman, I thought that your hand was up.
Thank you. It wasn't up, but now that you have pointed at me, so I've got to say something that, I was thinking about silently. Colleagues, I think we all understand that when it comes to female condom, it's not popular. And I've been whispering, in this table into saying that culturally, men are in charge. It might mean a woman brings the condom, but then the man says, not this one. So meaning that even men should be incorporated, in the sessions that, whereby awareness are done when it comes to female condom. Thanks.
Thank you for that, Ms. Bottoman, which I think we could always put in the table of the Department of Social Development, because they have Families Matter program, I know. So maybe that's something that they could also include. Mamekuto, sorry, but yeah, shoved you under the bus. I see your hand, sir. Thank you.
Good morning, colleagues. Good morning, Doc. Thank you to the team that has presented for the informative session. I just want to check, because this is one of the things, I work for Bumbingomso in the youth program for HIV prevention. I just want to check, maybe because this is a platform where HSRC that looks at what's going on nationally is in, and many people interested in research. Part of what was reported by Mr. Somael is the difficulty to find the people to put on treatment and losing some of those that are already on treatment. But on the other side, we're doing very well in tracking the number of tests we have done. Is it not time maybe for the department to consider revising that indicator to look at the number of people being tested? Because if we track the number of tests being done, you can test the same person over and over and you shoot that number up. But it means you will not be able to put more people on treatment or get more positivity results because you're testing the same people that already know their status. Thank you.
Thank you, sir. Okay, Ms. Bodoman is clapping for that one. All right, any other takers, colleagues? Or maybe we will ask the presenters when we go outside, when we're having tea break. Mr. Somaila, may I give to you, especially for the last one? Thank you, sir. Sorry.
Question, Mr. Mungwe?
No, Mhlekazi, ndibuza uba, is it something that the department is considering? Uba, ndaweni uba sibali test esizenzileyo for utreka i-HIV. Sibali abantu abatestiweyo because kuyenzeka kuba umancane enyakeni ateste mhlambi kabini kathathu depending on the circumstances. Now sizawubala i-test ezintathu ezenziweyo but besenziwa nomancane yedwa. Whereas if we track the number of people we test, sizawukwazi ukuthi kwezi test ziyi-100 siteste abantu abayi-70 and therefore si expect into okokubana abantu that we might initiate with treatment must be a percentage of that 70, not a percentage of 100.
Oh, thanks, colleagues. We do record the people that we test. They are registered in our facilities. But the direction of the indicator is saying, let's count the tests. This is an area that really is a concern because we don't consider the duplicates. I don't know, sometimes we off the view that we're even testing people that are already on treatment, who somehow wants to move from facility to facility in order to get themselves accepted in that particular facility, while they are defaulting in another facilities, only to be started again as new patients. So unfortunately, when we don't have a gatekeeping system on the testing, but we do have a gatekeeping mechanism for initiation. And you'll find that most of the time you'll find more patients are tested but less are initiated in certain districts because of that gatekeeping process. But for cases of testing, maybe the circles here, the champion for indicators and information management in terms of what to consider excluding the issues of duplication. Maybe we might want to consider on the new inputs. I'm not sure. She wants to comment.
It's okay, Mr. Somail. Thank you.
Thanks, Chair. He's putting me on the spot. I thought I sneaked in. And good morning to everyone, and morning, Doc. I think Mr. Somaila is right. We have, and I'm specifically now in a PHC facility. We have PHC facility utilization rate. This counts the patient and how many times they come to a facility in a given month. Now, our data suggests that our patients don't come more than 2 times in a month. As a province, as Eastern Cape, we are standing at 2.1. That's the first fact. So on average, our 0 to 19 and 19 and above will not come to a facility more than 2 times. And so already you can see that, duplicates could be there, but they are not necessarily a big factor. Secondly, for the testing of all ages, we do have an exclusion in the definition, and in how we record it. And the exclusion says that do not count repeat tests. So it's a matter of us, possibly as a department, reinforcing that when the clinician is in the room with the patient, to say, remember not to double count the patient twice, because it's standardized. It's required that as you test the patient, check if you have not tested them before. So it's just that messaging issue that we need to, to make it known to all the people that we are testing. Just moving on, I just want to say also still, colleagues, the fact that we are testing what is supposedly more than our target, and we are on the surface doing well, still doesn't mean that, we don't have a problem with initiations. Because even if we are testing more, it's good actually, because it means we are testing everyone. Do you see what I mean? We're testing everyone. The question still remains, where are the positive people? Anyway, we are testing over 100%, so we're testing everyone. Let's assume that we are also retesting, we are duplicating. But the question still remains, even in our duplication, we are still not finding the ones that are positive. And I'm sure this is where Mr. Somayela and all our civil society partners, this is the reality, as Utatumeli has said, that we need to consider. Could it be that, eventually, as Eastern Cape, we are really making inroads in our positivity yields? Maybe, just maybe, that, all our societal and behavioral and awarenesses are finally yielding results to such an extent that, our people are no longer becoming as positive as they used to. The third point, Eastern Cape has lost a substantial number of a population, and a population is the denominator for everything else. Our people have left for Cape Town and for Johannesburg and for other provinces. And so we have issues around our population. And I think Chris Honey, as well as George Gabi, are a point in case. Because the denominator for condom distribution is males 15 years and older. So it's not necessarily a good performance per se until you check how many males that are 15 and older are actually there in the two districts. So as we analyze data, we look at that. They could be doing 120, I've seen 129 for Chris Honey, but the question is, has the population that we have given them of 15 and above still there in the actual district, or they have left the province? And actually, when you look at the STI, you can see that these condoms are distributed. They are taken out. But whether they reach the bedroom, it clearly doesn't show that, because our STIs still remain high. And I'm glad, Mr. Somayela, that we have the partners, the people who are able to advocate for change, behavioral change at community level, and we do really appreciate all the work. And I'm also privileged to be sitting next to, CDC, Dr. Blandford, and I'm sure he has heard your cries. Everyone was saying funding and funding. And when Daddy's here, we know that hunger is gone. So thanks, Chair.
All right. Members, niyanibulala ngohlobo kodwa ke ngeke ndinivalele ngaphandle. Mr. Nokampula, then Reverend Novuka. Thank you.
Thank you, Program Director. Thank you for also the last speaker. Some of the points covered very well. We are just look at the program, celebrating the 20 years. This is a milestone. And the very fortunate part in this milestone, I have a privilege of working with the team in the Nelson Mandela, where they are doing a research on TB. Also, when they are doing key pops in the Nelson Mandela, I was there. So for me, it's a privilege also to meet them after plus minus 15 years ago. Mr. Davids and Dr. Hussein back in the days. But thanks, he's still alive, he's here. Mr. Davids, thank you for seeing you here. My comment, not questions, but something that we need to take it back home. Just to remind the Department of Health that the PLHCV sector got an MOU at the national level. And that MOU escalated to the provinces. And we found that in some districts, PLHV colleagues who are on program of receipts and program the project of SANAC are not allowed to enter in the facility to assist in terms of education and taking party, giving flyers, taking condoms and distribution. That is not happening. There are gatekeepers who want letters from district or letters from the PLHV sector as an entire organization. So this is the package, Mr. X, which I'm giving you to take it that should be an end, because we are here to assist and to work as a collaboration as a sector. Secondly, you will show us in your slide the part of condoms, but I didn't see how is the lubricants in the Eastern Cape going and the availability. If not available, why the lubricants? Thank you.
Thank you, Mr. Nogambula, Ref.
Morning, everybody. Uxolo talk. Okay. It's such that when I talk, and go familiar and do the research. But I'm noticing something, and then in the Anita, clarity. Ukut. When you reach targets, you reach your own targets, eh? Does that mean you've reached even impact? It targets, reaching the targets, diminish and only to the impact yalentu yenzayo. Ndifuna nje ukhe ndicaciselwe apho, because you'll find every time we've reached the target, we overreached. But is that talking to impact to the community or whoever? Thank you.
Thank you, Rev. Mr. Nogambula, ibingumphako to the DOH, umfundisi, maybe singanikela kuwe, Mr. Somalela, kule question about now that you have reached the targets, does that translate to an impact having been made to the people that you are servicing? Then I will give over to Doc. Thank you.
Okay, thanks, colleagues. Look, what I've presented here are the activity outputs. Report is not the impact reflection of the of what we want to achieve as a province. I think the assessment of impact will have to follow a different direction while reporting what we have done. And we're given a target based on what is expected to be done. And we're reporting on that one. Then I'm sure this study that you colleagues are going to reflect to a certain degree will indicate the impact of what we have been doing. Thanks, Chair.
Thank you, sir. Thank you, colleagues. A big round of applause for the presenters and the colleagues who participated. Thank you.
Thank you so much, colleagues. So we have now ended the first session of our program, and we are shortly going to take a tea break, noting that we are very late because of having started late, but we are going to have to try to rush through some of the activities. So we would ask that as we go for tea, we just grab what we need and then come back so that it's a working tea, and some of the discussions that we've had then can continue in the small groups that we have. Also having an opportunity while we have some of the colleagues here that you can also just have small discussions with them. So after tea, we also now want to get into the HSRC results. So we are going to just a bit of context, especially for those that we don't even know what HSRC is. We're trying to figure out what this SABSSM is that we are talking about. So we're just going to play a video and then get into the results. So we are also pleading with the colleagues that have joined online, do not move away from where you are. The session is not ending anytime soon, and then we also are ready then to also share. Noting that we know that you are jealous of us here and you want to participate in activities that we have, so we just quickly created a snapshot of the gallery that we have here. So we're just going to display that online just for you to also reflect. You've seen some people reflecting, some suggestions that came out of that reflection. So we also want to give you an opportunity to also reflect while we are grabbing our own tea. Obviously, after looking at the video, you can just quickly go to your kitchen, grab a tea, and come back and sit and watch us while thinking about what you want to type. There will also be a QR code of some sort that would also allow you to also type in your reflections based on that video. So we are trying by all means to also keep you busy, and you'd have also seen that Yolandi also allowed you to also express whatever question you have, a reflection that you have as we are going on with the session. So you may not be able to talk to us, but we are also looking at you and also making sure that we are allowing you to take part where possible in the activities that we have planned. So colleagues, if we can just try, it's now 11:30. If we can just try to make sure that by just 10 minutes of us, so by 11:40 we are back, if that would be really appreciated, just for us to grab and come back